to a new episode of the Young Tongues podcast. My name is Barbara Fountain and I am the founder and CEO of the Young Tongues, a peer-to-peer support charity for young tongue cancer patients across the globe. And I'm delighted to bring you a new episode with an expert today. Krishna, welcome to the podcast. It's lovely to have you. And
Hello.
hi, and our first question, we always start off the same way. We always want to get to know our guests beyond either diagnosis or, in your case, the profession. So, can you introduce yourself? Who is Krishna?
So I am Krishna Suchak. I'm a consultant head and neck pathologist at Barts, and I am mother of three unruly children who are now between 10 and 14, who are hard work, but also kind of my main motivation, really, with life, I suppose.
Absolutely, so lovely. And I guess let's start at the very basics. For anyone who doesn't know, what is a pathologist and what do you do on a daily basis?
So, a pathologist is a medical professional who analyzes tissue or fluid to make a diagnosis.
So when we have a biopsy, you're the person that is looking at the specimen, so to speak. And I guess for someone who's never been on that side of it, from a patient's point of view, how can we imagine, how does that take place? How do you look at our samples? Is there some gadgets or?
So it depends what you have. So if you have a small biopsy, so you would have an initial diagnosis, then what happens is, you know how it gets put into the little pot? The little pot reaches our lab, and then basically we would take out the tissue where it's been placed in formalin, so it's fixed, and we would then measure it, cut the specimen if needed, and then it would be sent for processing. And what happens there is it goes in a little wax block, which allows them to cut a section. And then once we have a section, we can look, it's stained, and we can look down the microscope to see what's going on with your tissue.
Amazing.
In the case of a cancer resection, it's a little bit more work because obviously we're looking not just at what the diagnosis is, but we're also trying to assess all the parameters of the tumour that we possibly can and the marginal status to kind of make sure it's out.
So in essence, you are the person that gives it its staging, is that right? Or do you give the advice to the surgical team and yeah, how does the interaction between the two of you work?
Yeah, so what happens is when we have your biopsy, we'll make the diagnosis. So that will be a histological diagnosis of the type of tumour you have, if you have a tumour at all. And then what happens is it goes to the multidisciplinary team meeting, which is for us, a head and neck multidisciplinary team meeting, where the histological diagnosis is put together with the radiological findings, and then you get a clinical stage of your tumour. And then when we get the resection, we're able to give a final pathological staging based on the tumour as a whole, or the parameters we can see, and if you've had a neck dissection, whether or not there was any positive lymph nodes in the neck.
Absolutely. So let's just rewind a little bit, and I always find it fascinating. How did you end up in this field? What was your sort of main motivator? What were your interests to end up as a pathologist?
So I think I was lucky at university. We had excellent pathology teaching, and I suppose that already you're kind of interested because you've got people who are really engaging. And then I suppose to the natural geek in me, pathology appeals because it's a real intellectual challenge. And then I suppose as well as that, there's the kind of more spiritual or however you want to call it side where I feel this is somewhere I can do good. This is somewhere I can achieve something for people. And I think anyone who's lost anybody to cancer or who has been through the journey will know it changes your approach to life, to what you want from it. And so I suppose every patient I can help is a kind of catharsis. And so it's a real, I mean, even now, I mean, I've been doing the job a while, and when people tell me about patients that I reported the resections and that they're doing well, and they tell me stories about them, I mean, I genuinely feel happy. Like it warms my heart. And you feel like, well, you know, this is really what it's about. So I think for me, that's my main motivator.
Yeah. Yeah, it's quite sad you never get to see us, do you? You just got like removed, but at the same time you're very intimate with us because you see a very personal part of our bodies that are going through
Yeah,
yeah,
and I mean, it must for us. Obviously, I don't get to meet the patients, but please have no doubt that you know, I know. So because I've worked in the same place for many years, if patients have recurrences or further specimens, I know them because I feel like I'm part of your journey, and believe it. You know, when I say really, we wish you the best. Like we really, when I get a new biopsy from a patient and it's negative, it's such a lovely feeling. So we are, although we don't meet you, we are really part with you all the way in the story.
really part of our pathway. That's really, you actually just mentioned something that I'm really interested in. So, one of the things we hear quite often at the moment is that there's lots of biopsies being done where actually it ends up being negative for cancer. But does that happen more often than actually getting a cancer for you in your daily work, or is it? Or I guess you're not just looking at cancers, are you? You're looking at a whole spectrum of other conditions that could be causing these abnormalities.
Yeah, so sometimes you'll get, you know, you might come in with something on your cheek or your tongue or your lip, and you're worried. It looks horrible, and sometimes it is a tumor, but oftentimes it can be something inflammatory. It can be an infection. It can be an autoimmune process, something like lichen planus, and these things can mimic tumours, and they can look very worrisome clinically, but actually it's okay. So again, that's a big part of our job is, you know, where everything comes in query cancer, saying actually this isn't cancer, but making sure those patients then get the appropriate treatment that they need. So not everybody will need surgery, for example. They may need simple antifungal, or they may need medical management in other ways.
Yeah, yeah, absolutely. And I guess, like you said about some of these are also precancerous conditions as well. So it can be like quite a long path in the sense that you hope they remain precancerous and are managed that way instead of turning into cancer. Um, I've recently been really lucky to go to a lot of different conferences and congresses, and I was at one which was about oral medicine, and they had a pathologist there where they spoke through different cases of different scenarios. Actually, most of them weren't cancerous, but one of the things I was quite struck by is that once the colour is added to a specimen, they look like works of art. I looked at some of those slides and thought, gosh, that would look really good on my wall. It's just, they're absolutely beautiful. But at the same time, I was looking at them and going, oh my God, how do you know what you're looking at and what you're looking for? Because it's all shapes and forms. So, can you take us a bit more into that world of what it is you are looking at on a day-to-day basis?
Yeah, so it's a steep learning curve when you start because it's unlike clinical medicine or dentistry. So when you look down the microscope, you see lots of pink and purple dots, and it's years of experience really where you gather this pattern recognition, and what you're looking for is where things don't look normal for where they are. And I say that because sometimes tissue in one place might look horrible, but it's okay for that place. It's tissue where it's in the wrong place and doing the wrong things. So, for example, for as you were saying about pre-malignancy, that's where there are changes in the epithelium, but it's not invading into the underlying connective tissue, and therefore it's not invasive carcinoma. And so that's a very important distinction. because if it's not in the tissues, it cannot go anywhere. And so if you can locally take it out, the patient is cured or treated, so to speak. And so a lot of our time is looking at the tissue very carefully, making sure we've examined all the tissue where necessary, and really piecing together the puzzle. What's happening? Can we account for why something looks the way it does? Or do we need to do additional stains sometimes to help us with that process? And it's very interesting. No two cases will ever look the same. And I suppose that's why I get all the grey hairs, but also it keeps you really, interested, and it keeps your brain on course to kind of look out for things, because you've never seen it all. And clinically, things might look, everyone might describe the same thing, but down a microscope, each one will look different. And so that's the kind of the game that we're playing.
Yeah, and an incredibly skilled job, and like you said, experience actually. How should I say this? Your value as an expert increases with more and more that you see. I'm just gonna. We've put some questions into our community and asked them to put some questions to you. So we'll just go through them before I go down my rabbit hole with all my questions. So we have Amy here. And she has said, I've always wondered what the process is when they receive a sample to make in the report. Just curious about the workflow involved. Grateful for those who do this work day after day in order to tell us what's quietly happening inside our bodies. So we spoke a bit about how it's we already spoke about the process of the sample arriving with you, being transformed and under the microscope. I guess what happens when you're interpreting it to the report, to the communication that goes to the surgeon, that part of the process?
So once you look down the microscope, you decide what you think this is, and then you will formulate your report, and that will be you'll write it, and your conclusion will be, if it's very obvious what this thing is, you will call it outright. Sometimes there's some ambiguity. You can't be 100% sure that it's invasive, for example, or you can't be 100% sure whether there's any underlying dysplasia, or is it all reacting to something like an ulcer. And then in those cases, you may have something a little bit more ambiguous in your report, where you might hold back from calling something outright, and you might recommend rebiopsy or a period of review, whatever may be appropriate. And I think there's also, I should say, that where there's some ambiguity, often showing it to a second person to try and make sure that you both agree on the diagnosis is really important. I don't think it's a sign of indecisiveness. I think it's just you're trying to do the right thing for the patient. So wherever necessary, I think it's important that cases are double reported to make sure the patient then gets the optimum treatment.
Absolutely. So the second question is from Jessica, and I have a hunch Jessica might be living in the US, because I don't know if we do this practice here in the UK, but we might do. She asks, I'm curious why some people's tissue is sent for genetic testing, while others are told it's not indicated or indicated. I'm trying to understand the decision making.
I think in the UK, routinely, we won't genetically test every oral cancer patient. So for some tumours, there's a very strong genetic fingerprint. And for those patients, for example, with certain colonic cancers, certain breast cancers, genetic testing there is very much recommended. It's part of the pathway. For oral cancer, it's a lot more complicated. It's often multifactorial. There's often multiple genes which may or may not play a role. And therefore, blindly testing everyone may not always be that helpful at this point in time. And also with the genetic testing, it's really useful when you then have something to offer those patients as a consequence of their genetic tests. But where you don't, how useful has it actually been? So the mainstay at the moment for oral cancer treatment in this country is wherever possible, if we're going for cure, we'll offer surgery, if that's a plus or minus radiotherapy. If that's not an option for whatever reason, then we would look at alternative treatment options. But as I said, at the moment, the mainstay would be surgical intervention, and that's what we always try and offer where we can.
Absolutely. And I'm just going to add a question to that, and that's the role of HPV and what the policy and the practice is. So is it now, does if in the UK, or if you know further afield, do our tumours all get tested for HPV? Is that standardised, or does that depend on which trust you're in?
No, so for every oropharyngeal tumour, so that's everything in the tonsil and the tongue base, they should be tested for P16 and HPV. P16 is a surrogate marker, and HPV-ish is the in situ hybridization test that looks for high-risk human papillomavirus in a tumour. So that should be done for all oropharyngeal malignancy. For oral cancer tumours, that's not the case, because oral cancer has less of an association with high risk HPV. Where tumours have a morphological appearance, so down the microscope, when we look at it, if it looks like it's got a bit of a viral feel, or where that's a possibility, we will always do it. I can only speak for our own trust, but we will always do that test where we feel there's a possibility that this tumour might be HPV related. But in the oral cavity, routine testing, no, they
That's
won't have it.
That's really interesting. So most of us are told that we're HPV negative with oral cancers, and I mean I know mine was tested up here in Norfolk, um, and obviously we know that HPV isn't quite as prevalent in the cavity tongue. There's plenty of research out there, and actually percentage-wise, quite a stark difference between base of tongue, oropharyngeal versus cavity of tongue. But what we find really interesting from a data perspective is the discussions we have about why there is a possible increase in younger people getting tongue cancer, and unfortunately a lot of the times we hear, oh, it's HPV related, and we're like, oh, but we're not in that camp. So that's quite interesting that that is not automatically done, because it becomes even harder for us to make that point that it's not HPV driving an increase in cavity tongue cancer. Although saying that, we don't actually know that, because we can't back it up with data, because the data doesn't exist in that sort of sense. So yeah, I don't know
So I
what your
would
take is on that.
say that often, so young patients, or where, for example, you're a non-smoker or non-drinker, where the usual so-called risk factors are not there, we would tend to do a P16 HPV to try and figure out, why has this tumour developed, even if sometimes it doesn't look like it will be HPV driven. Where we haven't got an obvious cause, or where the patients are younger, we would tend to do them, just to kind of rule that possibility out.
So that would explain why many of us are told it's HPV negative, because it is in our morphology report. That's great. So yeah, let's go to Lacey. Oh, this is quite a good question, because you kind of hinted at it earlier. So how can two separate pathologists read the same biopsy report and get two different conclusions?
So it won't be the biopsy report, it will be when they're looking at the down the microscope. Sometimes things are not always, so sometimes cells can look weird. They can look atypical or abnormal, but they are not neoplastic or dysplastic, which means they have no cancerous or precancerous propensity. The reason they can look weird is things like candida in the mouth can make things look weird, ulcers in the mouth, um, any trauma, things like that. All these kind of things can often make tissue look weird. And I say that because sometimes the distinction between something, whether something is odd because it's atypical, really atypical because it's dysplastic, or is it atypical just because there's other things going on, can be quite difficult. And that's where different pathologists may differ in their opinion. So some pathologists would, when they see some atypia, be a lot more worried, whereas others would hold back maybe and give the benefit of the doubt to these confounding factors that they're seeing and recommend, for example, a further biopsy. Or, for example, sometimes where there's a candidal superinfection, you may recommend antifungal treatment and then rebiopsy to assess whether there's any real epithelial dysplasia present, or whether the atypia was all due to the candida. So sometimes people will hold back based on these kind of other things that you're seeing in the tissue.
Absolutely. And I've got another question from two people. They asked the same question, Darren and Leslie. So I don't know if you'll know the answer to this. I'm just going to preempt that and say they are asking, do you think it's possible to cause the spread of cancer by doing the biopsy? Like, is there a risk of doing the biopsy and by interfering with the lesion to allow it to spread faster than it would have been possible to intervene on?
So theoretically, I suppose there is a theoretical risk from the tract. But I think there's been some good papers published in for bladder cancer and also for breast, where they have looked at that, whether patients develop anything where they've done the needle tract biopsies, and actually they haven't found any correlation. So I think the reassuring thing is, whichever, even if there was that theoretical risk, when you have your cancer resection, the area where you had the biopsy is removed anyway. So you can rest assured that has gone.
Yes.
So you don't need to worry.
Yes, I guess it more plays a role in healthcare systems where there is delay between diagnosis and treatment. I know NHS has its own struggles with that at the moment, but also I'm just conscious that one of these, I know one of the people who asked the question lives in a country which moves particularly slow between diagnose. Well, it was a long process to get to diagnosis and to treatment because they don't have the same type of healthcare setup that we do. So I guess in that circumstance, it could be quite important to to have that kind of evidence to be able to get treatment quicker. That's, I guess that's where the thinking behind the question came from. I'm not just going to, speaking about the tissue, now we know that there's different types of biopsy procedures. So there's one where they like what is it called, a puncture biopsy, or there's an incisional biopsy. I don't know if there's any other methods. As a pathologist, you can only work with the tissue you have. So how do you navigate that? Do you prefer one to the other, or do you know that basically it's all based on what the surgeon or the ENT consultant has seen? So how do you, or do you sometimes go back and say, actually, we need more tissue in order to get to some conclusions?
Yeah, so sometimes, so the incisional biopsy is where they will use a scalpel and they'll take an ellipse, and a punch biopsy is where they have a ready-made kind of punch that they punch into the tissue and remove it. Both of them are perfectly fine and valid for diagnosis. I think the problem comes sometimes where, let's say, you try and take a biopsy. Sometimes where the tumour is growing both outwards and inwards, you can take the top bit, but you don't get down into the bottom where we're seeing what's happening in the connective tissue. And at those points, you may need a further biopsy to try and get deeper down into the tissue. Or if, for whatever reason, they have difficulty getting a biopsy, it may be access, it may be that the patient was struggling with the procedure. And in those cases, again, sometimes a rebiopsy is recommended because you haven't got enough to make a kind of a definitive diagnosis.
Absolutely. And we'll just come to the last patient question, which comes from Anina. And she asks, does clear margins in a pathology report mean no cancer? Would it replace the imaging procedure afterwards, or is having imaging after always standard?
Yeah, so imaging afterwards is really important, and different depending on your stage and the prognostic features that were seen in your pathology report. That the interims between your scans may vary, but what's the fact that you've got your margins clear is brilliant. It means that when they've taken the tumour out, they've gone round, checked all the margins, and they're happy that the primary site is clear of any malignant involvement. So that's really important and very reassuring. And the reason for the scans is not because they doubt that, it's to make sure there's no onward development, either locally or anywhere else, local regionally, of any recurrence. So the imaging has a slightly different role, where it's then kind of surveying you on a long-term basis to ensure that you remain cancer-free.
Yeah, absolutely. And again, within our community, we do see different approaches. So we know if you're listening from the USA, you will have lots of scans. Definitely have gone straight after surgery and quite often after radiation chemo if you need that. And then, well, we have feedback that people have as many as quarterly scans in the first year, and then it starts to fade out. UK, very different. Most of us have a scan straight after surgery, and then that's it. Unless there's a reason and there's a bump or something appears. And obviously, a lot of us have ultrasounds, so especially any sort of bumps in the neck, and then with puncture biopsies to check them out. So I've had plenty of them. They're not as bad as the tongue biopsies, thankfully. So I'll take one of those over a tongue biopsy any day. Yeah. So I have another couple of questions. So I'm so fascinated, and one of the things I've always wanted to try and understand is, especially when we are looking at lymph nodes and lymph node involvement, um, is we've had consultants use words like, oh, there was only a little bit of cancer in a lymph node. Or so in my case, I will use my case, I had lymph node involvement in one single lymph node, and it was kind of put to me, that the pathologist really found it, like they looked really hard to find this speck. How do we, what does that look like? How do we interpret that type of information?
Yeah, I suppose that must be a hard thing for you to understand. And I'm just imagining, like my mum, when I talk to her about what I do, she always says to me, she has no clue. And the thing is, with a neck dissection, what happens is you will have, the lymph node chain dissected from your neck, and then our job as pathologists is then to search for basically as many lymph nodes as we can find in that neck. And the neck is divided into different levels based on anatomical location, and sort of you have level 1 down to level 4. And our job is to, by level, pick out as many lymph nodes as we can, and then look at each one down the microscope and assess whether there's any tumour in there. The ideal would be we find loads and loads of lymph nodes and nothing has any tumour. It's good for you because it means your neck is staged as an N0, which is your best prognosis. If we manage to find one or two, maybe small little metastases within the lymph node, that's still, it's okay. The whole point is that we're trying to find them for you because we can then guide onward treatment. And if we do find anything in the lymph node, what we're trying to do is we measure them to see how big they are. We also will assess what level we found them, and we will assess whether there's any spread out of the lymph node. So if there's no spread out of the lymph node, again, that's a good prognostic sign. And if your lymph node was found higher up rather than lower down, that's also a good prognostic sign. So that's all that stuff that we do with the neck dissection is to try and glean as much information as we can. And even if we do find adverse features, they're not there to fill you with dread. The reason we find them is that then your onward treatment can be optimized, so the oncological management will be decided based on what we find on the neck dissection. So I think, what we're looking for is as many nodes as possible to make an informed decision for your onward care.
Yeah, and it definitely helped me. I mean, it put me into a predicament at moments of time because I had to make a very difficult decision with the one person being pro and the other anti. Turns out that was a whole spiel and they wanted me to make the decision. Um, but I was really interested. I remember at the time going like, what do you mean they only found a speck of cancer? Like, surely cancer is cancer. Like, is there different levels of it? So that was a really great explanation of how to see that. And also, I didn't know that, you look at, is it inside the lymph node or has it gone out of the lymph node? So again, that's really interesting in terms of where you find it as well. And I guess my next question was looking into the future. There is lots of talk about AI and new diagnostics ways and how technology is going to impact the future of cancer care and diagnosis. How do you feel about it, I guess, as a pathologist, but also what are your hopes that you're hoping to see of things in the pipeline? Maybe you're already seeing some things happening or hopes for the future, for example.
I think it's an interesting area. I'm not the best with technology, and so I have my own apprehensions just because I'm not very tech savvy. But I can see it would be a really useful adjunct in several situations, particularly for things like quantifying percentages of expression of various things, of analysing proliferative fraction, how active or how proliferative is the tumour, those kind of things it would be very good at. And I think in the future, it will be a useful adjunct. I think in my lifetime, at least, I don't think it will replace the job of a pathologist, because I think as I said, there's so much variability, so much variation between different tumours and within the same tumour, that I think in this life, for me in my career, I don't think I'll see such a significant change where we've shifted into an AI world. But I think the possibilities for it are very interesting for uses as an adjunct. I think that may very well happen in the near future. And there's already talks of it in use in research forums and so on.
Yeah, absolutely. I mean, we're part of a piece of research that is going down that route, but more as seen as a tool to assist pathologists rather than to replace the pathologist, because ultimately it doesn't matter how good AI is if AI has never, if a human hasn't told AI what it is, it will not know what it is. So, and with there being so much variability, but I think more in terms of, I think for us young people, one of the things we're really conscious of is the delays that we're seeing in diagnosis, which can be linked with some of the behaviours of not wanting to send people for a biopsy unless they need, by primary healthcare physicians, we should say, not secondary, but by primary healthcare physicians, because we know that the system's overloaded and we know that a lot of oral cancers come back as negative. So wouldn't it be great if there was some sort of pre-screening so we can prioritise your workload in terms of some sort of technology, but we'll leave that up to the inventors and the med techs to figure that one
Yeah,
out.
no, I think as you say, the rules of it as an adjunctive tool or as a screening kind of tool, that is a valid possibility. And I think the problem in primary care is where the younger cohort of oral cancer patients don't fit the traditional mould, the index of suspicion isn't there, and therefore that's why they won't jump to biopsy. So I think these tools may prove helpful, but I think also it's a certain amount of education as well of primary care practitioners, in sort of saying, well, yes, you don't have all the risk factors, but this doesn't look right. Um, and then that's also necessary to go along with anything else that's created. Thank you so much for having me.